know how common PCOS is. So let's begin that topic. You just have to listen to this lecture at 2x speed for 2 to 3 times to memorize it. So starting with the pathophysiology of PCOS. Group of symptoms, various presentation, different pathophysiology. Previous term, Steen-Leventhal syndrome. I'm glad it's not being used anymore. Etiological factors, environmental factors, complex genetic trait, chromosome number 2, chromosome number 9, lifestyle factors leads to excessive androgen production, defect in folliculogenesis, defect in insulin action, insulin resistance, defect in gonadotropin secretion and action, obesity. It can also happen in thin and lean individuals. Excessive androgen production, source ovaries are the main source. Adrenal glands, minor contribution. Increase DHEAS, pathophysiology. Androgen levels, normal levels in female less than 70 nanogram per deciliter. PCOS you will find more than equal to 70 nanogram per deciliter, but less than 200 nanogram per deciliter. This will lead to hirsutism. Complication, dyslipidemia. Increase LDL and decrease HDL. Risk of coronary artery heart disease. Follicular toxicity of androgens, growth of follicles arrested, no maturation into Graafian follicles. Complication, dyslipidemia, risk of coronary heart disease. Ultrasound, small unruptured follicles, not cyst, arranged along periphery of the ovary, necklace appearance. Multiple follicles, number more than equal to 12, Rotterdam criteria, size 2 to 9 mm, volume of ovary more than equal to 10 cc. Anovulation, no ovulation. Infertility, decreased progesterone, no corpus luteum. Secondary amenorrhea, oligomenorrhea, less than 9 cycles per year. During pregnancy, increased risk of abortions. Lab finding, increased serum testosterone, increased serum DHEAS, increased LDH, decreased LDH, HDL, decreased progesterone, increased anti-Mullerian hormone more than equal to 7.3 gram, increased small follicles. Insulin resistance contributes to dyslipidemia, leads to theca cell hyperplasia. Oversensitivity to LH stimulation due to loss of normal cutoff. Increased androgen production. Complication, acanthosis nigricans, Heron syndrome, DM. Insulin resistance, independent of obesity. In PCOS patients, 70% are obese, 30% are not obese. Normally, increase luteinizing hormone, increase androgen from theca cell up to a limit. Applied aspect, all patients of PCOS, oral glucose tolerance test to be done every 2 years. Insulin resistance present, repeat oral glucose tolerance test every year. Acanthosis nigricans, clinical manifestation of insulin resistance, occurrence of dark, velvety and thick skin. Sites, nape of neck, axillary region, groin, under breast tissue. Heron syndrome, hyperandrogenism, insulin resistance, acanthosis nigricans. Obesity, present in 40 to 80% of patients. not a defining feature. PCOS can occur in thin individuals. Pathophysiology: dyslipidemia aggravates insulin resistance, androgens in adipocytes, aromatase, increased EI, estrogen breakthrough bleeding, menometorrhagia, heavy plus irregular cycles. Investigation: E2 E1 levels normal 2:1, obese PCOS female 1:2. Menstrual cycle abnormalities: thin PCOS patients, secondary amenorrhea, most common normal estrogen levels. Obese PCOS patients, secondary amenorrhea, menometorrhagia, increased E1. Potential complications: endometrial cancer, ovarian cancer plus minus, non-alcoholic steatohepatitis due to increased estrogen, contribute to dyslipidemia, aggravate insulin resistance due to obesity. Defect in gonadotropin secretion. Pathophysiology: PCOS, increased pulse frequency of gonadotropin releasing hormone, increased luteinizing hormone by pituitary, theca cell hyperplasia, increased luteinizing hormone cells throughout the cycle, absence of LH surge, anovulation, follicle stimulating hormone with LH ratio 1:2 or 1:3, FSH normal, LH increase, normal FSH LH 1:1. Day 2 or day 3 of cycle, best time to evaluate LH and FSH. Normal females, LH surge, PCOS, constant high LH. Note: anovulation in PCOS is due to follicular toxicity of androgens and absence of LH surge. Diagnosis of PCOS: hormonal profile in PCOS, serum testosterone increase, DHEAS, LDL, anti-Mullerian hormone, E1 in obese female, luteinizing hormone unchanged, follicle stimulating hormone, E2, prolactin, thyroid stimulating hormone decreased, HDL, serum progesterone, serum HBG due to effect of androgen and plus insulin. Rotterdam criteria: increased androgens level, biochemically hyperandrogenemia, increased serum testosterone level, clinically hyperandrogenism, hirsutism, ovulatory dysfunction, secondary amenorrhea, oligomenorrhea, polycystic appearance of ovaries on ultrasound, more than equal to 12 follicles, 2 to 9 mm size in one or both, ovaries of volume or volume of ovary more than equal to 10 cc, any two positive provisional diagnosis of PCOS. Next step: 17 hydroxy progesterone levels, screening test to rule out late onset CAH, congenital adrenal hyperplasia. Less than 200 nanogram rules out congenital adrenal hyperplasia. 200 to 800 nanogram ACTH stimulation test diagnostic. More than 800 nanogram confirms late onset congenital adrenal hyperplasia. Not a diagnostic criteria of PCOS: obesity, LH-FSH ratio, insulin resistance, menometorrhagia, necklace appearance on ultrasound, more than equal to 12 follicles, 2 to 9 mm size, both included as polycystic appearance. The American and European societies criteria: more than 20 follicles, 2 to 9 mm size, ovaries may be normal in PCOS. Consequences of PCOS: short term complications, menstrual irregularities, hirsutism, alopecia, infertility, insulin resistance. Approach to PCOS plus secondary amenorrhea. Routine investigation. Urine pregnancy test negative. Luteinizing hormone increased. FSH normal. Estrogen levels increased or normal. TSH normal. Thyroid dysfunction, amenorrhea. Serum prolactin normal. Hyperprolactinemia, negative feedback on gonadotropin releasing hormone. Additional investigations: serum testosterone 17 hydroxyprogesterone normal to rule out late onset congenital adrenal hyperplasia. Progesterone challenge test positive, withdrawal bleeding on administering progesterone for 5 days and stopping. LH normal, FSH, LH increase. In secondary amenorrhea, PCOS, primary amenorrhea, androgen insensitivity syndrome. Complain of hirsutism, acne, irregular cycles. Next step is doing serum testosterone levels. Diagnosed case of PCOS: lipid profile, urine glucose tolerance test, ultrasound to assess endometrial thickness. More than 12 mm is a reproductive age female with PCOS. Indication for endometrial biopsy. So I will show you what is given actually in getting a screening for PCOD. So you send them for an digital ultrasound. Pelvic, transvaginal is more sensitive than abdominal, but if the patient is not comfortable, you can give them transabdominal views only. And then along with that, you give them blood test. What else you will test in blood test? Full-blown PCOS, classical PCOS, phenotype A, all three Rotterdam criteria positive: high testosterone levels, ovulatory dysfunction, polycystic appearance of ovary on ultrasound. Management of PCOS based on primary presenting feature of patient: menstrual irregularity, most common, infertility, hirsutism, insulin resistance. Hyperprolactinemia is to be ruled out in all cases of PCOS. Prolactin present, adrenal glands, more androgens. First line: lifestyle modification plus weight loss leads to spontaneous ovulation in 5 to 10% cases. Management of menstrual irregularities. Pubertal young female, irregular cycles plus minus due to anovulation may persist up to 3 years after menarche. Cycle length 21 to 45 years. Indication of evaluation: more than 90 days of cycle length. Onset 3 years after menarche. First line management: drug of choice OCPs, very low dose pills. Ethinyl estradiol less than 20 microgram. Progesterone third 4th generation, Mala D, Mala N may be used. Mechanism of action of OC pills. Estrogen and progesterone present in the OC pills will then cause downward regulation and decreased secretion of LH and FSH that will cause separation in the ovaries. And if you remember, LH used to increase androgens. When ovaries suppressed, there will be anovulation, there will be less androgens, and there would be decreased natural estrogen, which lead to endometrial thickening, because in PCOS there is an endometrial thickening. So, and if it is more than 12 then we have to do endometrial biopsy. Duration 21 days, 3 weeks on and 1 week off. Advantage of OCPs in PCOS regularizes cycles. Treatment of hirsutism, as it will decrease androgens. Contraceptive benefit, protects against endometrial cancer. Progesterone, cyclically every 12 to 14 days in the second half of the cycle, more than methoxyprogesterone acetate, MPA, most commonly prescribed, called ELISA. Progesterone advantage, regularizes the cycle, protective effect on endometrium, decreased risk of hyperplasia and cancer, minimum duration 12 days. MPA, methoxyprogesterone acetate, 10 to 20 milligram into 5 days. So starting dose is 10 milligram, facilitates withdrawal bleeding. Disadvantage, does not regularize cycles, do not protect effect of and on endometrial days. Hirsutism, drug of choice OC pills, decreased LH FSH, decreased androgens. Estrogen of OCP, increased serum hepatic binding globulin, decreased free testosterone. Management of infertility. First step, advise weight loss followed by trial of natural conception plus folic acid supplementation. First line management, pharmacological therapy. First line drugs, ovulation inducing drugs, letrozole. Drug of choice, clomiphene citrates. Second line of drugs, clomiphene citrate plus metformin, clomiphene citrate plus dexamethasone. OCP is followed by clomiphene citrate. HMG, recombinant gonadotropins. Second line management, laparoscopic ovarian drilling. Third line, pulsatile gonadotropin releasing hormone or in vitro fertilization. Clomiphene citrate, SERM, selective estrogen receptor modulator. Non-steroidal, centrally acting anti-estrogenic, causes ovulation induction. Mechanism of action, central action, blocks estrogen receptors in hypothalamus and pituitary. T half of clomiphene citrate is more than T half of estrogen. Pituitary falsely interprets this as low estrogen. Increased LH and FSH, maturation of multiple follicles and ovulation. Peripheral action, clomiphene citrate binds to peripheral estrogen receptors in endometrium, endometrial thinning. Cervix, thick cervical mucus, unfavorable for pregnancy. Prerequisites, intact hypothalamo-pituitary ovarian axis, normal FSH levels. Composition, N-clomiphene potentiates anti-estrogenic action, zuclomiphene, T half, 2 weeks. Duration 5 days, day 5 to 9. Dose, starting dose 50 mg once daily. Maximum dose 150 mg once daily. Follicular monitoring. Day 10 onwards via transvaginal ultrasound, daily alternative, follicle size 18 to 20 mn. Natural ovulation or ovulation triggers injection HCG similar to LH. After 30 to 36 hours, ovulation occur. Intrauterine insemination. Adverse effects, hot flushes, most common. Ovarian cyst, second most common. Headache, vaginal dryness, breast tenderness, multiple pregnancies. Ovarian hyperstimulation syndrome, least common. Visual disturbances. Diplopia, blurring of vision, scotoma, indication for immediate stoppage. Advantage, no risk of teratogenicity or ectopic pregnancy. Prerequisites, intact HPO axis, normal FSH levels. Features, composition. N-clomiphene potentiates anti-estrogenic acid, zuclomiphene. T half, 2 weeks. Okay, you already read this. Clomiphene citrate versus letrozole. Category, clomiphene and letrozole. Clomiphene selective estrogen receptor modulator. We read that here. SERM. So clomiphene is that and letrozole is aromatase inhibitor. Mechanism of action, centrally acting, blocks and receptors in hypothalamus and pituitary, increased LH, increased FSH. Peripherally acting, androgen, aromatase, estrogen decrease, loss of negative feedback, LH and FSH, increase LH, increase FSH. Starting dose 50 mg and letrozole is 2.5 mg once daily. Maximum dose 150 mg, 7.5 mg once daily. T half is 2 weeks and 48 hours. Follicular development, multifollicular, monofollicular plus multifollicular. Risk of multiple pregnancies 7 to 10%, 3 to 7%. Effect of endometrium and cervix. Blocks estrogen receptors, no effect, hence increased chances of pregnancy. Live birth rate increases. Double increases in letrozole, hence drug of choice. Side effects, hot flushes most common, vaginal dryness well tolerated plus no anti-estrogenic side effect, headache rare. Uses, drug of choice for ovulation induction, second drug of choice for PCOS. Drug of choice for PCOS, prerequisite, intact HPO axis and normal FSH level. Contraindications, Sheehan syndrome, pituitary ablation, hypogonadotropic hypogonadism, Kallmann syndrome. Second line management, clomiphene citrate plus glucocorticoids, dexamethasone. Indication, clomiphene resistant PCOS plus increased androgens, DHEAs. Principal, glucocorticoids suppress adrenal glands, decrease androgens. Clomiphene citrate plus metformin. Indication, clomiphene resistance, PCOS plus insulin resistance. OCPs with cold clomiphene citrate, duration 2 months followed by clomiphene citrate. Principal, decrease LH and decrease androgen. HMG, source, urine of postmenopausal women. Composition, 75 intrauterine LH, 75 intrauterine FSH plus impurities. Indication, hypogonadotropic hypogonadism, drug of choice for ovulation induction. Second like drug of PCOS, all cases of in vitro fertilization. Adverse effects, multiple pregnancies. Ovarian hyperstimulation syndrome 5 to 15%. Increased risk of spontaneous abortion. Advantage, no teratogenicity. Recombinant injection follicular stimulating hormone, purified form of FSH. Disadvantage, expensive. Laparoscopic ovarian drilling. Principal, burn ovarian stroma, destruction of theca cell, decrease androgen. Advantage, no risk of multiple pregnancy, no risk of ovarian hyperstimulation syndrome. Disadvantage, risk of premature menopause due to follicular destruction. Rule of 4, 4 sites for 4 seconds, 40 watts power. IVF in PCOS, indication more than 35 years, plus factors contributing to infertility. Drugs contraindicated in PCOS plus infertility, spironolactone, anti-androgenic, ambiguous genitalia in male body. OCPs, except in clomiphene resistant cases. Note, selective estrogen receptor modulators capable of ovulation induction, clomiphene citrate, tamoxifen, raloxifene, or meloxifene, SERM that does not cause ovulation induction. Component of centrochroman contraceptive, Shia. Management of insulin resistance, drug of choice, metformin, insulin sensitizer. Advantages of metformin, helps in weight loss, mild anti-hirsutism action, decreased chance of gestational diabetes mellitus in PCOS patients, can be continued during pregnancy, no teratogenicity. Decreased risk of ovarian hyperstimulation syndrome in PCOS patients. Indications, insulin resistance, unable to lose weight, ovulation induction along with clomiphene citrate. Note, causes of hirsutism, PCOS. Most common, idiopathic hirsutism, androgen producing ovarian tumor, androgen producing adrenal tumor, Cushing syndrome, hirsutism plus diabetes, hypertension. Pregnancy luteoma, hyperplastic mass of luteinized ovarian cells, not a true tumor. Theca lutein cyst due to increased human choreographic gonadotropin similar to subunit of LH. Hyperprolactinemia, drugs contraindicated in hirsutism, danazol. And gestrinone.